Hello, my name is Erin Carlton, and I'm an assistant professor at the University of Michigan, and I'm thrilled to speak with you today about pediatric long-term outcomes after sepsis. I have no relevant conflict of interest, but I do have some disclosures for some grant funding, as seen on this slide. Over the next 10 to 20 minutes, we will review the features of post-intensive care syndrome among children who survive sepsis, identify risk factors for these new morbidities, and finally review recommended practices and strategies to mitigate such long-term effects. But first, let's start by thinking about a patient case that likely sounds familiar. You're caring for a 6-year-old girl who was admitted with bacterial pneumonia. On the first day of admission, she developed respiratory failure, requiring intubation and mechanical ventilation. She would develop septic shock, requiring vasoactives. In total, her ICU stay was 7 days, and she was discharged from the hospital after 12 days. Even though she's been discharged, the impact of sepsis may continue, sparking many questions. Will she have new medical problems or require new therapies? What about school? How will this affect her? How will this affect her siblings? But taking a step back, it's important to recognize that sepsis impacts many children and their families. Each year, there are over 1 million pediatric sepsis cases worldwide. Fortunately, the vast majority of children survive hospitalization. And with that, there's been increasing recognition of the challenges facing children who survive sepsis, as well as their families. In thinking about survivorship, we can look to our adult colleagues who formalized the concept of post-intensive care syndrome pediatrics, or PICS, over a decade ago. They recognize that critical illness impacts both the family and their survivor of critical illness and can lead to challenges in mental health, such as anxiety and depression, cognition, including memory and attention, and physical functioning. Importantly, they also noted that the symptoms of PICS can be long-lasting and are often under-recognized. In thinking about how this post-intensive care syndrome may impact the children we care for, it's important that we recognize why children are different from adults. The children that we care for are at various stages of growth and development. We care for children that are 2 months old, 2 years old, or 12 years old. Additionally, we recognize the key role that families play in both the child's health as well as in their recovery. And finally, we must remember that what happens in childhood can impact the trajectory of an individual over the course of their entire lifetime. Dr. Manning and team recognized these important differences in the pediatric population, and with that, in 2018, developed the PICS-P, or Post-Intensive Care Syndrome Pediatrics framework. As you can see in this conceptual model, the child experiences the PICU alongside their family and in the context of their baseline health. This PICU experience then can impact not only the physical, cognitive, and emotional health as described in the adult framework, but the PICS-P framework now recognizes the impact on social health. Over the next several slides, I will present examples of the ways in which each of these domains may be impacted by sepsis. First, we'll talk about a child's physical health. This is often evaluated using overall measures of functional status, such as the POPC, or Pediatric Overall Performance Category, or the FSS, the Functional Status Scale. But it also can include specific characteristics like technology dependence, such as tracheostomy or gastrostomy tubes, pain, problems with sleep, and other new medical diagnoses. The first study we'll talk about is the SPROUT study. This was conducted in 26 countries and demonstrated a point prevalence of 8.4% of children with severe sepsis hospitalized in the ICU. In this study, they also evaluated functional status and showed that 1 in 5 children have new functional disability when discharged from the hospital based on the POPC score. Recently, in a cohort of critically ill children with sepsis, our group evaluated the impact of sepsis on specific medical conditions and found that 1 in 5 children developed a new or had worsening of these medical conditions within 6 months of sepsis hospitalization. Additionally, when compared to matched controls, new chronic respiratory failure, supplemental nutritional dependence, and chronic kidney disease were more common after ICU sepsis hospitalizations compared to other ICU hospitalizations for other causes. Transitioning to cognitive health, prior studies show cognitive impairments, including deficits in attention or worsening neurocognitive outcomes, do occur after critical illness, which often includes sepsis. Risk factors for such declines include younger age at critical illness, oxygen or mechanical ventilation requirements, and opioids. And finally, it's important to recognize that these deficits may persist beyond the acute hospitalization period. Uniquely, the PICS-P framework considers the social health of the child, as well as their family members, and how critical illness can impact the ability to go to school, their relationships with peers, parental employment and family finances, as well as the impact on siblings. When it comes to the ability to go to school or work, both children and parents often miss school or work after their PICU hospitalization. In this secondary analysis of the RESTORE clinical trial, we found that kids missed nearly 2 weeks of school following discharge, while parents missed a median of 2 days. Additionally, this illness impacts siblings, where 20% missed school during their siblings' hospitalization. Finally, when we think about how critical illness may impact school performance, we can look to the recently published study from the ANZIX group. This study included over 5,000 PICU survivors and found that 1 in 7 did not meet minimum standards on standardized testing. And when we look at the specific diagnoses that children who survive PICU hospitalization have, we can see that a higher proportion of children with septic shock do not meet testing standards compared to other acute illnesses such as trauma, bronchiolitis, and asthma. In thinking about the emotional impact of sepsis, we can look to the health-related quality of life scales, which is a multidisciplinary construct that includes physical, mental, social, and emotional domains that focus on the impact health status has on the quality of life. There's been much prior work describing decline in health-related quality of life among sepsis survivors. Recently, the LAPS study showed that 1 in 3 children have significant decline following sepsis, and that this persists to 1 year after discharge. And while it does not directly fit into one of the PICS-P domains, healthcare utilization can certainly impact each. This increased healthcare utilization includes readmissions, outpatient visits, and emergency care, which has been shown time and time again to increase after sepsis hospitalization. How can we help now? What can we do about this? A review from Doctors Prescott and Angus suggests that things promoting recovery can be thought of in 3 categories: early hospital care, things to be done prior to discharge, and what can be done after discharge. This structure provides a framework, but it's important to remember that some of the items or interventions may be pertinent throughout the patient's clinical course. First, we can go to the guidelines. In 2020, the first Pediatric Surviving Sepsis Campaign guidelines were published and provided 77 recommendations for care of children with sepsis. And while this can be a whole talk in and of itself, they include things such as recommendations for initial management, including antibiotics, source control, and resuscitation. Next, it's important to think about the prevention of pain, agitation, and delirium, as these can have significant impacts on sepsis outcomes for children. Again, recent guidelines provide recommendations including the assessment of pain, family engagement, prevention of delirium, and early mobility. And as we move out of the acute critical illness and continuing towards discharge, it's imperative to think about nutrition, implementation of therapies such as physical therapy, occupational therapy, and speech therapy, as well as medication reconciliation. That includes restarting home medications that may have been stopped, as well as discontinuing medications that were started in the acute phase and are no longer needed. As pediatricians, we recognize the importance of anticipatory guidance, which we must impart to our patients and families, letting them know the symptoms of PICS-P, that some children may be at higher risk, and that the PICU hospitalization can impact not only the child, but also their sibling and other family members. It's also important that we let families know what resources may be available in their communities. Finally, support after PICU hospitalization, and especially for sepsis, is an evolving area that we in the critical care community are increasingly recognizing as important. Collaboration with outpatient providers and appropriate referrals are key. Interestingly, there have been some sepsis-specific follow-up programs that have conducted post-discharge assessments, helped in care coordination, and have referred for specific testing as needed. So as we bring this all together, the optimal support of children who survive sepsis and to limit the long-term impact of sepsis begins in the hospital and continues home following discharge, and requires the care and collaboration of all treatment teams as well as families. In summary, we know that sepsis impacts a child and their family, both during and after hospitalization. And as described in PICS-P, physical, cognitive, emotional, and social health can be impacted by sepsis. We can, however, try to limit these impacts by optimizing long-term recovery, which includes the recognition and treatment in all phases of care, including early in the hospital, as one moves towards discharge, and then after hospitalization. Thank you again for this opportunity to speak with you today.